Hello, everybody. This will be a talk on cardiogenic pulmonary edema, and this is something that I gave a talk about a long time ago in 2013. However, it came to my attention that the sound was messed up as apparently YouTube has screwed up some of my videos. Not exactly sure why, but anyhow, so I'm going to go about and do this, and hopefully this one will come through. I have had to re-record a few of my videos, and so I give a brief update here. However, really nothing has changed, so we're really just going to be doing the same lecture over again, but this one will have sound, so hopefully you appreciate that. If you haven't had the opportunity yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can get there by clicking the I button on the upper right-hand corner of the screen or on the link below in the description of the video. If you consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. And if you subscribe, you'll have access to some of my premium videos in which I go over case reviews, formulating differential diagnosis, and treatment plan, things that will come in handy for you for your future steps and for clinical practice. Thank you very much in advance for your consideration. So cardiogenic pulmonary edema is basically pulmonary edema where the heart is to blame. The heart's not pumping properly, there's increased pressure in the heart, maybe due to a valvular problem, and ultimately this increase in pressure in the heart or the heart's inability to pump properly results in an increased pulmonary pressure, i.e. PCWP, pulmonary capillary wedge pressure. Which is, as I said, secondary to ineffective filling or pumping of the heart. And this can be due to a variety of things. It can be due to congestive heart failure. I would say that is the most common, followed closely by valvular disease, which can be aortic or mitral. Arrhythmias, if there's a constant arrhythmia, heart is not pumping out blood properly, that's going to increase the pressure. This is all a game of pressures here. And then myocarditis, again, affecting the heart's ability to pump properly. This can be acute or it can be chronic, so you want to keep that in mind as well. Some other causes of pulmonary edema that are non-cardiogenic would be something like a lymphatic obstruction. This results in decreased drainage from the interstitium, and that's going to result in edema. Excess volume administration, decreased oncotic pressure due to a low albumin state, and then damage to the lung itself. That's going to lead to an inflammatory process, which is going to cause fluid to get out into the interstitium. So this is just the pathophysiology of how it works, and when you have cardiogenic pulmonary edema, you get pressure building up in the heart, which ultimately gets transferred into the pulmonary capillaries. This increased pressure is going to force fluid out. That fluid then goes into the interstitium and causes the pulmonary edema. So this is where you have the increased pressure, and that pushes fluid out. You do have some amount of fluid that can get retaken up by the lymphatics. However, that's not very much, and certainly not going to be enough if you have cardiogenic pulmonary edema. It's not going to be enough to fix this problem. So it really just overwhelms this whole process here. The most common presentation of congestive heart failure is, in fact, pulmonary edema, and it can be quite dramatic. The symptoms may include dyspnea, which is difficulty breathing, cough, they may have a pink frothy sputum, they may have anxiety because of low oxygen, and chest pain. On physical exam, you'll note tachypnea, tachycardia, and that's typically due to the underlying cardiac causes. They may be invisible distress due to low oxygen. You're going to note rales and rhonchi and wheezing, which is just due to the disturbances to the lung tissue itself. You may note a variety of murmurs depending on what the cause is. You may also note cool extremities and skin mottling. Please remember your ABCs. Have intubation supplies handy in case the patient goes into respiratory fatigue. Remember that because the patient is going to be poorly oxygenated in many cases, because their lungs are so inundated with fluid, they need to breathe more. in order to get more oxygen. So with that, their diaphragm and accessory respiratory muscles can become fatigued. Their respiratory rate will drop off, and they can become acutely acidotic. So in that case, you will need to intubate those patients. When you're working these patients up, you want to make sure that you get basic labs. A chest x-ray is going to be absolutely indispensable in helping you determine whether this is acute or chronic. An echocardiogram can be useful to determine the actual cause, if it is in the heart or not, an EKG for the same reasons, and a BNP, which is a marker of congestive heart failure. So when you have a patient with cardiogenic pulmonary edema, typically it just is going to present with as pulmonary edema. So they're going to have difficulty breathing. Their lungs are going to sound wet and wheezy sounding. They may have some tachycardia, but you don't necessarily know just from that whether it's cardiogenic pulmonary edema or not. So this is just your basic workup for pulmonary edema. And through the chest x-ray, the echo, EKG, you're going to find out that it is cardiogenic when it is. So this will give you everything you need to know. In a patient who does not need intubation, the best next step is going to be chest x-ray when you suspect pulmonary edema, and that's pretty common sense. You got a patient who's having difficulty breathing, and they got rales and bronchi. You want to know what's going on in those lungs. So chest x-ray is your next best step. The best treatment is going to be ACE inhibitors and loop diuretics to help get some of that fluid off. And that's also very good treatment for congestive heart failure in general, which is the most common cause of cardiogenic pulmonary edema. Some stereotypical presentations of cardiogenic pulmonary edema. A patient presents with worsening dyspnea on exertion, has a history of high cholesterol, diabetes, and smoking, and coronary artery disease. This is systolic congestive heart failure. Probably the most common cause out of the congestive heart failures would be the systolic congestive heart failure. A patient who presents with worsening fatigue dyspnea and has a history of untreated strep infection and has had a long-standing murmur, this would be, thinking back to your valvular issues, a mitral valve stenosis due to the untreated strep infection. And this is something that happens over time. If you had an untreated strep infection 2 weeks ago, you're not going to get mitral valve stenosis from that. Typically, this develops with time that valve becomes damaged. If the patient presents with severe dyspnea and shortness of breath and has a long-standing history of uncontrolled hypertension, then you may think of diastolic congestive heart failure. It could also be systolic, but that would be a possible presentation of diastolic congestive heart failure. You can have one or the other, you might have both. Ultimately, patients do, in many cases, get both. If the patient is being hospitalized and is a few days post-MI and suddenly develops severe dyspnea, pink frothy sputum, and a new systolic murmur, then we think of acute causes. And one of the acute causes, particularly when you have just had a heart attack, is a papillary muscle rupture. And these patients are very, very, very dramatic presentation, and often these patients die. This is one of the more severe, I would say this is the most severe complication of a heart attack. So just because a patient has a heart attack and you get their heart beating and everything seems fine, those first few days are critical, and this is certainly a complication. It's why we want to observe these patients for around a week after they have a heart attack. Observe them in the hospital. This is something that will typically happen within the first few days after a heart attack. If the patient's very tachycardic, presents with anxiety, chest pain, and shortness of breath, and has an EKG that shows wide QRS complexes with no discernible P or T waves, what is that? Well, it's this right here. So just me telling you that probably wasn't good enough, but if you saw this picture, you should know immediately that this is a monomorphic ventricular tachycardia. Absolutely, all day long, this is VTAC. This is, again, another acute presentation of cardiogenic pulmonary edema. When you have VTAC, although the heart is beating and pumping in most cases, it's not pumping sufficiently, and so that blood gets backed up, the pressure increases in the pulmonary capillaries, and you get edema from that, and it's going to be an acute presentation. We'll look at some chest x-rays, how you can tell acute versus chronic. A lot of times the history is going to tell you that, but the chest x-ray is helpful as well. So the emergency treatment for cardiogenic pulmonary edema is very similar to the emergent management of congestive heart failure. You'll do an IV ACE inhibitor unless contraindicated, and that would be captopril or something along those lines. IV furosemide, IV nitroprusside or nitroglycerin, and then and those things help to lower the pressure in the pulmonary capillaries, reduce the amount of fluid that the patient has in their circulation, and both of those are going to help reduce the flow of fluid into the pulmonary interstitium. And eventually that fluid will get taken up by the lymphatics, but it will take some time. This isn't going to help immediately. You want to give them full oxygen, face mask, CPAP, BiPAP, whatever it takes. Intubation is also fine if necessary if they have respiratory fatigue. Morphine can be good to help with pain. Also identify and address any underlying causes as soon as possible. So if they have systolic congestive heart failure, you may use dobutamine, etc. So you want to address the underlying cause if you've identified it. You want to sit the patient upright. Obviously, that's going to help bring that fluid down to the bottom of their lungs rather than have that fluid all spread out. You want to have at least some, even if it means the lower part of the lungs are a little bit more inundated with fluid. The important part is that you have more surface area that can exchange oxygen. And then reassurance. Obviously good, because we don't want these patients to get anxious. If they get anxious, they need more oxygen, and that's already a problem. So in early pulmonary edema, if you got a metabolic panel, it doesn't need to be a CMP, it can be a BMP, whatever. It will show that the patient is in respiratory alkalosis, and this is typically due to the high respiratory rate and the release of CO2 from that high respiratory rate. So you would see a high blood pH, a low PCO2, and a normal bicarb. This is respiratory alkalosis. In later pulmonary edema, you'll see a respiratory acidosis, often due to respiratory fatigue. Respiratory fatigue does not necessarily have to be dramatic. It's just a decrease in the respiratory rate that is problematic because it's not commensurate with their hypoxia. And this would reflect as a low blood pH, a high PCO2, and a normal bicarb. So how are you going to go about analyzing the chest X-ray in suspected pulmonary edema? Like I said, usually with history and good physical examination, you pretty much already have your diagnosis before you do a chest X-ray. However, the chest X-ray is going to lend some insight as to whether or not this is I mean, you're going to know it's pulmonary edema, but this will tell you, is it cardiogenic? And if so, is it acute or chronic? And there are other things that you're going to want to get, like an echo, to really nail down that it is cardiogenic. But you get also a good idea with the chest X-ray. So first off, alveolar infiltrates are a must. Like with any pulmonary edema, again, something you're going to know on physical examination when you're hearing wheezing and you have maybe some hypoxia and stuff. So you have alveolar infiltrates, which I'll show you a picture of. You can also see those curly B lines, which requires a little bit more, you got to look at it a little bit harder, and you're not always going to see them, but most of the time you will. And curly B lines are just fluid infiltration onto the pulmonary interstitium. Edema will usually be seen most prominently in the lower lung fields, which are the dependent areas. Fluid gets pulled down by gravity, and so it'll be in the lower lung field, but that can go higher and higher if you've got more severe edema. Of course, if the patient's been bedridden for some time, then it's going to be in whatever area is most dependent. Hilar obscurity is frequent, so you want to look at the sort of upper field of the heart and look, make sure you can see those vessels. A lot of times you will not be able to see them. They'll be obscured. You may see and this is one of the more dead giveaways, a blunted costophrenic angle. So costo, ribs, phrenic, diaphragm, It's that angle, that nice angle that you normally see on the lower sides of the lungs. You have this nice sharp angle, and that will be blunted or completely obliterated with pulmonary edema, particularly because those lower lung fields are the more dependent areas. So the fluid is going to go down there first. This is like the lowest part of the lung field, so that's going to be where the fluid is going to go first. So you may notice that. The cardiac silhouette is actually really important if you suspect cardiogenic pulmonary edema. So this will give you an idea of whether it's chronic or acute. It's not perfect, but it does give you an idea. So if you see an enlarged cardiac silhouette, that points towards a more chronic condition because the heart has adapted over time to the higher pressures. Either due to a high blood pressure, which could lead to systolic congestive heart failure, or due to a cardiomyopathy and so forth. Enlarged cardiac silhouette, chronic condition, usually systolic congestive heart failure, which I would say is the most common cause out of all of these. Chronic valvular heart disease can lead to an enlarged cardiac silhouette since you've got pressure building up, especially if you have like an aortic or mitral valve stenosis. A normal cardiac silhouette points towards either diastolic congestive heart failure or, in more cases, a more acute cause. So valvular rupture secondary to MI, although you're probably not going to be getting a chest x-ray right away in these patients. You'll diagnose that with echo after treating them emergently if these patients survive at all. Myocarditis, arrhythmia, volume overload. So those are all acute causes. They're not going to alter the geography of the heart, so you're going to see a normal cardiac silhouette even though the heart may be what's actually behind it. So just because you have a normal cardiac silhouette does not mean that it's not a cardiogenic pulmonary edema. And this, again, is where echo is going to help you. So like I've said, chest x-ray will give you a big clue, but your history, physical labs, and often an echo or an EKG are going to be needed to really nail down your definitive diagnosis. So here you can see a normal chest x-ray. Notice, first of all, that you see very nice clear lung fields. This is very important too because this is one of the first things to go, this costophrenic angle. You see this nice acute angle on either side, and this is good. This is normal. You see your diaphragm here. This nice acute angle is what you should see. The cardiac silhouette is normal size. And then that's all I got here. And then the hyla is very clearly visible, these vessels that are coming out. These are very clearly visible. Now let's compare that to pulmonary edema. You do not see a very good hyla. It's kind of obscured. These vessels up here you don't really see as with as good definition as you can see them here. The cardiac silhouette is probably upper limit of normal here. It's really hard to tell. I would not call this an enlarged cardiac silhouette, but I would be suspicious that this is cardiogenic because this heart looks on the upper side of normal. And then you can't really see the costophrenic angles too much. They don't look too bad. So this would be kind of a mild case of cardiogenic pulmonary edema. So the diagnosis here was acute mitral regurgitation following an MI. So it was acute. The cardiac silhouette was normal. Really not a severe pulmonary edema, but it doesn't take a real severe case to cause some symptoms and some wheezing and stuff. This is a slightly more severe case. You can see here that we really have an obscured cardiac silhouette. We don't even know if this is enlarged. It probably is, but we can't really tell because we have so much edema in the lower lung fields. The costophrenic angle is totally blunted. We don't really see hyla at all. Engorged pulmonary vasculature, costophrenic angle is pretty much gone. And you can see this is probably an enlarged cardiac silhouette, but there's so much edema down here, it's really hard to tell. It's really just obscured. Diagnosis here was minor pulmonary edema due to systolic congestive heart failure. So really the only way you'd be able to tell that the heart was enlarged here would be an echo. Although you might be able to tell if you got a lateral chest x-ray, which by the way you should always get. If you're taking step 3, make sure anytime you order a chest x-ray that you're ordering both AP and lateral. You need to get both. Obviously, here we have a large cardiac silhouette. You can see it's going all the way from almost to the side of the rib cage, all the way halfway down on the opposite side. So this is certainly enlarged. We don't see much hyla here. You can see you got pulmonary infiltrates, but you can see these curly B lines here, which are just these sort of linear infiltrates. And the costophrenic angle looks all right. It is a little bit blunted, though. And like I said, you're going to see more blunted costophrenic angles in people who have been upright more because the fluid will accumulate in the lower lung fields. So if they've been bedridden, you may not see that, but you would see, if they've been bedridden, you'd probably see more infiltrates in the upper fields, for instance. So obscured hyla, curly B lines, alveolar infiltrates, and obviously your enlarged cardiac silhouette. And the diagnosis here is pulmonary edema due to chronic mitral valve stenosis. That's resulting in the enlarged cardiac silhouette. And then finally, here is a lateral decubitus chest x-ray. This is obviously a patient who's been bedridden for some time. Notice how normal the lungs look on both sides. I mean, you got some infiltrates, but the hyla looks all right. And the costophrenic angle on the non-dependent side looks pretty good. But you see all this fluid that's accumulated in the right lung. And it takes some time for this to happen. So just because, if the patient's been upright and then you were to take a decubitus chest x-ray, you're not going to see all the fluid accumulate like this right away. It takes some time for the fluid to trickle down this way. So this just points out that the fluid does not have to be in the lower lung fields. It's really in the dependent areas. But patients who've been upright for some time, it's going to be in the lower lung fields. And that's all I've got for you for cardiogenic pulmonary edema. If you have any questions, write me a note below. Otherwise, I will see you next time.